Let's start. I start recording. Okay, so welcome. I'm Dr. G. We are going to start talking about the urinary system. Okay, so let's start with the urinary system. So there are some few things that we need to get on kidneys. First of all, the urinary system is going to be composed by many structures. Basically, as you can tell, we have um, uh, two kidneys. We have actually the ureters, we have the urinary bladder, and we have the urethra. One thing I want to ask you about is, tell me, do you know why probably we have the left kidney higher than the right kidney? Somebody can tell me?
Is it because of the diaphragm?
Yeah, why? Because why the right kidney is going to be a little bit lower than the left side.
Because of the liver.
Excellent. So actually we have the liver there, right? So
Uh-huh.
the liver is going to make some compression on the right kidney, and that is going to make the kidney a little bit lower, and that is the answer. So we have here there is, well, the kidneys are going to measure between 10 to 12 centimeters and 4 to 5 wide, and about thickness is about 3 centimeters. So one of the locations we call the kidney is number one. Always remember the kidneys are in the retroperitoneal space. So I'm giving you some tips that probably are coming for the final. And the kidneys are retroperitoneal. Other organs that are retroperitoneal are going to be, for example, the pancreas. You can see the aorta and you can see the IVC. So all these, the adrenal gland, of course, they are going to be retroperitoneal organs. One thing that we need to remark here, you notice that here in the center of the mid sagittal line, we are going to have the spine. And here the spine we have on the left side the aorta, and on the right side the IVC. When you're going to see images, CT scan, MRI, or X-ray, you need to get oriented in that way. All right, so we have the kidneys, and we have the location, and the kidneys are located side by side, so laterally to the spine. So it's not too lateral to the spine; it's almost very close to the spine. You can tell that even the tip of the upper pole of the kidney is almost touching the spine. So that is actually very close to the spine. So the kidneys are lateral to the spine, and the kidneys are retroperitoneal organs. So just to remember, give you another tip. For example, the retroperitoneal organs are important to know which one is retroperitoneal, which one is not. Why? Because in the venous return of the kidneys, because of the retroperitoneal position, all retroperitoneal organs are going to drain directly into the IVC. So, for example, we have pancreas, we have adrenal glands, we have kidneys. So those organs are the second, third, and fourth portion of the duodenum, for example, that you will learn later, uh, are going to drain into the IVC. And all right, so let's start with that. So we have two kidneys, two ureters, the single urinary bladder, and the urethra. So let's continue. All right. So what I want here, and I don't know if I can write down something here. We are going to learn what are the functions of the kidneys. So if you remember, let me try to, if I can draw this. This is F, this is R, this is E, this is S, and this is H. This is the word fresh, right? Fresh, what does it mean when we are talking about functions of the kidney? Is that F means filtration, R means reabsorption, E means elimination or excretion, S means secretion, and H means hormones. So those are all the functions of the kidney. Question. So we have already some notion about kidneys, especially the nephron, etc. And the filtration, where is going to happen? The filtration mostly happen in the glomerulus. In the glomerulus. Reabsorption. Why do we call reabsorption? Why we don't call absorption only? We call reabsorption because, for example, kidneys are going to reabsorb water. How come? Because the first time that the water are going to be absorbed is at the level of the intestines. So they go to the blood go filtrated to the kidney, and the water start to uh, be reabsorbed. So it's the second reabsorption. So that's why we call the reabsorption. And we will see that mostly, for example, glucose, amino acids are going to be reabsorbed by the kidney. Elimination and secretion. What is the difference of excretion, elimination, or secretion? Excretion or elimination in this case are products that are going to be completely out of the body, and we are not going to use it. So those are kind of waste products that are coming from the metabolism of the body. So what is excretion is some substance or element that are going to be completely eliminated uh, uh, out of the body. And secretion will be a substance that is going to be produced, but it's not going to be excreted. It's going to be reused. That is actually secretion, and we are going to give some um, some examples. So we have filtration is the glomerulus. We have R is the reabsorption, mostly happen in the convolute tubules. We have excretion, elimination. For example, we have the urea. That smell, for example, when we go to those gas stations that do not have a cleaning, they don't clean the bathroom, the restroom, that smell is actually urea. And this urea is totally eliminated by the kidneys. Secretion. Secretion, for example, we are going to talk about bicarbonate. We are going to talk about hydrogens. And when we talk about secretion, that you know that the kidneys are important part of to control the pH of the blood. As you can tell, bicarbonate is an alkaline substance, alkaline. So it's the baking soda that we have at home. So this bicarbonate, that is a product of the reaction of the carbon dioxide with the water, are going to give the alkalinity of the blood. So if, for example, your pH of blood is acid, so what is going to do the kidney? The kidney is going to retain bicarbonate. So to make it into the normal range again. If you are too alkaline, your blood is too alkaline, what the kidney is going to do is to eliminate bicarbonate. And this elimination is called actually, is going to be the secretion of they can secrete, for example, hydrogens. If you need, if your body is more alkaline, if your blood is alkaline, the kidneys, the convolute tubules are going to secrete hydrogens into the blood to make the pH normal. And hormones, H. What hormones we are going to have? We have the erythropoietin. You know, you heard about the erythropoietin. Erythropoietin is an hormone secreted by the tubules of the kidney, and this is going to stimulate the red bone marrow. So you can notice, for example, a patient who has a chronic renal disease, the kidneys are not working properly, and what happened? Most likely, the erythropoietin is not being produced by the kidney. So you can tell in the patient's face that the face of the patient become pale. Why? Because you have anemia. What is doing the erythropoietin? Erythro, red blood cell, poietin formation. So erythropoietin is going to stimulate the bone marrow to produce red blood cells. Okay, if you don't have erythropoietin because the kidney is damaged, that is going to produce a diminishing number of red blood cells, anemia, in other words. Well, we are going to talk in a few moments about that. So we have let's keep going. So that is, another substance that is going to be secreted by the kidney is the vitamin D. Vitamin D. The vitamin D. How is going to work the vitamin D? Vitamin D, what is produced, the absorption of calcium. So that's why when we go to the market, we have this vitamin D and calcium in the milk, is because vitamin D promote the absorption of calcium in the intestine. So the vitamin D, what are the sources of vitamin D in your body? Number one are going to be the exposure to the sun. So your skin, our skin, when it's exposed to the sun, is going to produce vitamin D. But this vitamin D is not active. This vitamin D produced under the skin is not active. Then the vitamin D that is not active is going to be absorbed by the vessels. They go to the blood circulation and is in the kidney when the vitamin D that is not active become active. So in conclusion, kidneys are going to activate vitamin D. The other source of vitamin D is diet, of course, right? Vitamin D by diet and vitamin D produced by the exposure of the skin to the sun. Another substance that we need to remember is, and we are going to see soon, is the renin. The renin. The renin is a very important, some people call enzyme, some people call hormone, so it's kind of discussion there. But the renin is a substance produced by the kidney. And the renin is going to produce some control of the blood pressure in the patient. Okay, so we have all these elements. Let's keep going. Let me go here to the, okay, so let's go here. All right, so you can see here, what is the functional unit of the kidney? The functional unit of the kidney, sorry, just a moment. Okay, so the functional unit of the kidney is going to be the nephron. Nephron. How many nephrons do we have in every kidney? We have about 1 million nephrons. 1 million nephrons. It's important for imaging when you have some contrast substance to make from angiography or whatever. They are going to be important to know how is the absorption of this substance in these nephrons. Anyhow, so the nephrons, we have about 1 million every kidney. So each kidney have 1 million nephrons. And what happened if you destroy 60% of the nephrons in one kidney, for example, that kidney is going to enter into kidney failure. But remember this, the lab tests are going to become normal. Why? Because the other kidney are going to compensate. So it's something that we need to be careful. So that's why we rely in imaging and lab tests. And definitely nephrons is the, always remember, is the functional unit of the kidney. Okay, so what are the functions of the kidney? The functions of the kidney will be fresh, filtration, reabsorption, elimination, excretion, secretion, and hormones. So all these are the functions of the nephron. So let's go to some images here. And here you can see the one kidney, and we have different components. And I would like you to please let me see where's the drawing here. Okay, here we have the kidney, and we have two main divisions. Number one is the renal cortex. I'm going to point to the renal cortex. So all this clear area, can you see all this area? all this area is the cortex. Plus, I want you to see you here, this area. These are part of the cortex. So those are in between some structures in the other portion of the kidney. So all this is cortex. All this is cortex. All this is cortex. Okay, so we have cortex and we have the renal medulla. Renal medulla is going to be everything that is going to be besides these projections are going to be the medulla. What we have in the medulla? These pyramids. So we have about 7 to 8 pyramids every kidney. And here after the cortex, after the medulla, we are going to have the pelvis, the renal pelvis. The renal pelvis is going to drain into the ureter. Okay, so if we go back to the one of the pictures that we showed you before, here in this picture, you can see here the aorta that is on the left side of the spine, and the aorta is going to give a branch that's called the renal artery. This is at the level of lumbar, the vertebrae lumbar number 2. So at the level of L2 is where is going to, that is the level of the where the renal artery is going to come out from the aorta to give the blood supply to the kidney. So let's go back here again. So this is the renal artery. The renal artery is going to divide in many branches. We don't need to know the segmenta, the lobular, the arcuate, or whatever. So just remember that we have many branches coming from the renal artery, and they are going to go directed to the glomerulus, to the nephron, okay, to the nephron. So all these small branches you see here are going to be having one nephron at a time, one nephron at a time. So we have about 1 million of these guys. All right, so let's see. We are going to talk about the nephron now. The nephron is the functional unit of the kidney, and we need to know the components of the nephron. Here we have the nephron is composed by, can you see these vessels? These vessels coming, those vessels are coming from the branches of the renal artery that are going to get into the cortex that I show you here. See, they are coming, and these are the vessels. These vessels then are going to form a tuft of capillaries that is called the glomerulus. It's like a labyrinthic of group tuft of capillaries. So these capillaries are going to be called the glomerulus. Glomerulus is singular, but in plural we call glomeruli. Glomeruli. Everything that ends in I in Latin is plural. All right, so this glomerulus is surrounded by a structure called the Bowman's capsule. You can see here the Bowman's capsule. So this Bowman's capsule is going to be the receptacle of the filtration, because the glomerulus, you don't see here very clear, but the glomerulus has a small openings. It's like a colander. When you are going to drain spaghetti in a colander, so the spaghetti is too big in order to go through the holes, right? So this similar here with the glomerulus. So what is happening is that structures that are very tiny, no bigger than the openings in the glomerulus, are going to escape, and they are going to go into the next part of the nephron. That is what we call the glomerular filtration. Glomerular filtration. Okay. If somebody has some questions, or you want me to repeat, or you want me to clarify, just please, just feel free to speak up. All right. So here we have the we have the Bowman's capsule surrounding the glomerulus, and then they are going to get into the proximal convolute tubule. This is the proximal convolute tubule. Can you see proximal convolute tubule? Proximal convolute tubule, proximal convolute tubule, proximal convolute tubule. Then after that is going to produce like a hairpin or a loop that is going to be all the way down here, and that is called the Henle's loop. What is the Henle's loop here? It's showing here, here, loop of Henle. or Helmholtz loop. Okay, so we have ascending, descending. We don't mind. We don't care about that at this moment. Just remember that we have after the PCT, proximal convoluted tubule, we have the Helmholtz loop. After the Helmholtz loop is coming another portion that is the distal convolute tubule. The distal convolute tubule. So this is the Henle's loop of Henle, and they are going to continue from this point all the way here up to the next point. Here is the distal convolute tubule. All this is the distal convolute tubule. And one more thing I want to tell you, that is all about the nephron. So the nephron goes from the glomerulus, Bowman's capsule, down to the distal convolute tubule, period. So there is actually the next one, that is the collecting duct, do not belong to the nephron. Do not belong to the nephron. So one question here. So where are going to be mostly located the glomerulus? The glomerulus are located mostly in the cortex of the kidney. So where are located now these collecting ducts? Can you see, can you try to imagine this one nephron and imagine two nephrons, imagine 200 nephrons, imagine 200,000 nephrons that they have this portion of the collecting duct? Where is going to go this collecting duct? So if we go to the previous picture, you can see, hopefully you can see some rays, some lines here coming all the way in the pyramid. These lines are going to be the collection of collecting ducts. The nephrons are mostly located in the cortex. 80% are going to be located in the cortex, 20% in these areas. So we call the Bertin columns. We don't want to mention that at this moment. So after here we have the glomerulus, the Bowman's capsule, the PCT, we have the Henle's loop, we have the distal convoluted tubule, then the collecting duct, that is the last portion, are going to enter into the pyramids, but many of them. So that's why you have this configuration as arrays. So that is going to drain into what we call the calyx. This calyx, so they put calyx here, but actually we have the minor calyx, the major calyx. Just this area we are going to call calyx. And what is doing this calyx is going to collect all the fluid that are coming from the nephrons. So they're coming nephrons. Again, the last time, glomerulo, Bowman's capsule, the PCT, Henle's loop, the distal convoluted tubule. Then the collecting duct enter into the pyramids, and they are going to drain the fluid into the calyx that is called the renal pelvis altogether, renal pelvis, and they go to the ureter. Right? Is that clear? All right, so hopefully it's going to help you with that. Okay, so here we can see that number one, I will, in this picture, we have the glomerular filtration are going to happen in the glomerulus. Then we have the fresh, right? Fresh filtration. Then we have the excretion. The excretion is, for example, the urea. Urea is going to be eliminated completely towards the urine. So the urea, as you remember, is part of the metabolism of the proteins, right? The proteins are going to form ammoniac. This ammonia are very toxic. It's going to take it by the liver, and the liver turn the ammonia into urea that is less toxic. Okay, so that's why when you have kidney failure, you cannot get rid of the urea, and the urea accumulate and go especially to affecting the nervous system. You start to have delirium, dementia, and you can enter into coma when you have higher risk, higher levels of urea in blood. Okay, so we have here the reabsorption. Reabsorption is a part of the fresh word that I want you to remember, and reabsorption means that they are going to get all the elements needed for the body. For example, glucose. Glucose is going to be totally absorbed by the proximal convoluted tubule. Why I say proximal convoluted tubule? Because 80% of the absorption happen in the PCT, in the proximal convoluted tubule. 15% 15% of the reabsorption is happening in the distal convolute tubule, And the Henle's loop, they have mostly the function of concentrate the urine. That means that they are going to produce some reabsorption of fluid too. So mostly the convolute tubules produce reabsorption. Okay. The elimination, excretion, we talk about that. The secretion is going to be here in this area. Here we have the distal convolute tubule, and the distal convolute tubule, they are going to go in between always between the efferent and the efferent arteriola. So this is the efferent coming the blood into the glomeruli. Filtration is happening, is passing, but not all the fluid is going to pass. They are going to come back through the efferent arteriola. And in between these two vessels, the efferent and the efferent are going to pass a portion of the distal convolute tubule. This portion is the one who produces the renin. The renin is going to, at the end, result in the secretion of aldosterone from the adrenal gland, and that will produce reabsorption. And you know the sodium loves water. So if you increase the secretion of renin, that is going to produce the absorption of water. More water in the blood, increase the blood pressure. Okay? So any questions so far? Everything is okay? Can you still hear me? Hello? Okay. Just a moment. All right, so let's continue. So can you hear me, please? Hello? Okay, so I hope that you are listening. Can you write me down something in the questions area, please, just to be sure that we... Okay, perfect. Okay, thank you. All right, so let's keep going. All right, so here we have, and I don't know how to delete this, just a moment. Okay, so here we have again our nephron. Our nephron is going to be with all the components, what are the glomerulus, the Bowman's capsule, the proximal convolute tubule, the Henle's loop, and the distal convolute tubule, period. So nothing else. Can you see again, the distal convolute tubule go in between the efferent and the efferent. And this is the close-up for this structure. And these cells of the distal convolute tubule are going to be modified. This modification are going to produce cells that have this name. We don't care about that name at this moment, but these cells, the juxtaglomerular apparatus, these cells are going to secrete the renin. Okay, all right, so let's keep going. So again, here we have, if you see here, the distal convolute tubule. The distal convolute tubule is going to pass between these two vessels, and that is the this portion of the DCT, distal convolute tubule, produce the renin. So again, can you see here the same thing? All right. So let's talk about the ureters, and then we are going to talk a little bit about pathology. That is going to be really, really interesting. All right, so we have the ureters, and the ureters are coming out from the renal pelvis, and you can see here very wider area of the renal pelvis, correct? And then it's getting very narrow suddenly. So why is that important? Is the uretero-pelvic junction. Ureter-pelvic junction. Is because of the ureters, the lumen of the ureters is measured only 3 millimeters, no more than that. And you can see that any formation of stones, could be calculus like calcium, can be actually, the first area can be stuck, is going to be in this portion. So when you're going to do images of X-ray or CT scan, you're going to find one of the three areas that are going to be most likely the nail of the stone in the urinary system is here, where I'm pointing now. So it's the uretero of ureters, uretero, pelvic, renal pelvis junction. Okay? All right. All right, so we have the urinary bladder, and the urinary bladder is a temporary reservoir for urine. So how much urine can you retain? Mostly the urinary bladder can retain about 800 cc. If you have, for example, a bottle of wine, mostly is having 725. So one bottle and a little bit more is the capacity of the urinary bladder. One thing I want to tell you in addition, the kidneys, both kidneys are going to receive about 650 mLs of blood every minute. So that means about the size of a fluid of a bottle of wine, for example. I don't like to drink, but it's just easy to make an example, okay? So we have here so this amount of blood is going to go into the kidneys. So then the kidneys are going to filtrate, that means from this 650 are going to pass into filtration, glomerular filtration, 120 mLs. So it's about 5 to 4 times the volume that the kidney receive. All right, so it's about 25% of the volume that getting into the kidneys are going to get into the filtration, into the glomerular filtration. So we have 120 mLs. So in 1 minute, in 2 minutes, we have 240. So that means that is a quarter of a liter. So in 4 minutes, we have half a liter. And in 8 minutes, we have 1 liter that is going to pass into the nephrons filtration. But we don't have urine as much as that, right? So what happened is the kidney is going to reabsorb from every 120 mLs per minute that is filtrated, the kidney reabsorb 118 mLs. So that means that what is going to go to the renal pelvis, to the ureters, and to the urinary bladder every minute are going to be about 40 drops of urine. 40 drops of urine. So that is what is going to be we are forming every minute as a urine. So the urinary bladder is going to be composed. The urinary bladder is measured about 6 centimeters. If you measure the size of your finger, it's about 7 centimeters. So the urinary bladder is not that big as we see in the books. So it's actually much smaller than the real thing. But they can be distended in about 800 mLs. So when you have 400 mLs, so the half of the bottle of wine, so about that is when you start to feel the sensation to go to the bathroom. Okay, so the wall of the urinary bladder is going to be about 3 millimeters thicker. And here we have is composed by a smooth muscle. So a smooth muscle, what does it mean? That is actually an involuntary muscle. So you cannot control the urinary bladder, but you can tell me, okay, but I can stop my urine when I want. Yes, you can, right? And the thing is that we have here in the urethra, in the exit of the urinary bladder, we have actually sphincters. We have internal and external sphincters, and those sphincters are actually striate muscle. So you can control those sphincters. So that means that the urinary bladder contracts, but you can actually stop the urine if you want, because this muscle in this area, there's like a ring around the urethra, are going to produce the stop of the diuresis of of the urine. All right. So let's keep going. So here we have here the sphincters I was mentioned here. Here, the urinary bladder, when you are doing the CT scan or MRI or or ultrasound, you need to see, for example, here the walls. The walls are having some regular shape, but always you need to look for your images from outer to inner, from biggest to smaller. So in order to read the images you're going to have in front. And one of these is the surface of the lining of the urinary bladder. If you see some mass, some overgrowth, that should be symmetrical. One side to another side, always compare side by side in order to know that it's a symmetric view. If there is no symmetric, something is wrong, is going on, wrong. Okay, one more thing here. The ureters are not going to drain into the urinary bladder on the top. They are going to get behind the urinary bladder, and that is the level here, here, and here. What we call the ureteral openings is where the urine is going to drain. So that is what we call the trigon. Trigon. Can you see the shape of a triangle? So it looks like a triangle, right? So that is called the trigon. Okay, so let's keep going. So here's the representation of the urinary bladder and the ureter. See, the ureters don't drain here on the top. They don't drain here. Of course, there is one of the very common, one of the most common malformations at birth time is the duplication of urinary system, and one of these is the ureter. Sometimes they drain on the top, but those any abnormality or any different from normal, they can lead into more often infections, for example. All right, so let's talk about the urine. The urine is sterile at the time that is in the urinary bladder, so there is no bacteria. So, but at the time that getting outside in contact with the environment, start to be contaminated with what? With bacteria. Now, we need to remember about the pH of the urine, and that is a very important thing. Let me go here if I can write down something. Okay, so here we have the pH 6. So to remember, if you draw something like this, look at this. This is the urinary bladder, and this is going to be the urethra. Let's put it like that. So that looks like a 6, right? So that is the pH of the urine, and this is very important. I will tell you why. The pH is 6, so properly you can say that is plus minus 0.5. So you can tell 5.5 up to 6.5 are actually the normal pH of the urine, and that is very important and very relevant when we are talking about urinary tract infections. Why? Because bacteria hate acid. So if you see 6 is mostly pH, acid pH, right? So if you have pH 6 or 5.5, it's very unlikely that you can have some bacteria or bacteriuria. So that means presence of bacteria in the urine. But if your pH, the urine, go down below above 6.5, that is going to turn more alkaline. Bacteria are start to grow. So when you go to the doctor and the patient is getting some sample of urine, they telling you, wait, we are going to check the urine and we are going to come back. So one of the things that they're going to do is to measure the pH of the urine. If the pH of the urine is alkaline, that means that probably you are already getting an urinary tract infection or UTI. All right, so you are a student for imaging. So here we have just to mention the specific gravity. Specific gravity is something that in the medical field we use when you have, for example, to see if the patient having dehydration. For example, we have less density here, or specific gravity, and here's more dense. What does it mean? The urine is more concentrated, and here the urine is less concentrated. If you are, for example, dehydrated, mostly your specific gravity is going to be this and this level. Okay, so BUN Serum creatinine is a waste product of the muscles, and this is the value that is going to be 0.5 to 1.2 milligram per deciliter. BUN is the blood urea in nitrogen. So nitrogen, so urea is going to be 10 to 20. 10 to 20 is the normal value. So there is no glucose and no proteins in the urine. So let's see. For example, somebody of you probably are thinking why diabetic patients are going to have glucose in urine if all the glucose is being absorbed by the kidney. All right, so the answer is going to be simple. So if you remember that if you can compare the kidney like a vacuum, the vacuum can vacuum or absorb some amount of dust. But if you put, for example, 10 kilos or 20 pounds of dust, the poor vacuum cannot absorb all the dust, correct? So the same thing with the kidney. So when you have some amount of glucose, the kidney can be able to reabsorb that glucose. But if you have huge amount of glucose, the kidney is not able to reabsorb all the glucose that are going to pass through. We can go in more detail when, for example, the receptors for the transportation of glucose into the cells or into the cells of the convolute tubules are going to be totally saturated. So the reabsorption of glucose cannot go through the cells. Okay, let me see if I normal drawing. Okay, perfect. So let's keep going. All right. So, what is the composition of the urine? We have urea, uric acid. Uric acid is important for what process? If you remember a process called gout, gout is the accumulation of uric acid, and mostly the uric acid where it's coming from. The uric acid is coming from the decomposition of DNA and mostly is higher when you eat excessive amount of meat. And these purines that are coming from the meat are going to turn into uric acid. Creatinine is a waste product of the metabolism of the muscles that is relatively constant all the time. So that's why we keep it as a parameter to measure the function of the kidney. We have electrolytes, we have sodium, chloride, we have phosphates, sulfates, and some pigments. So if somebody can tell me why the urine is yellow sometimes and why it's white, because the yellow is coming from the red blood cells are going to live about 120 days. The red blood cells die and they are taken by the spleen. The spleen destroys the red blood cells and the red blood cells are going to release the bilirubin. The bilirubin is going to go into the bloodstream. They go to the liver and the liver put the bilirubin in the gallbladder with the bile. The bile is excreted. They go to the intestines and the intestines, the bilirubin is yellow, and that's why some bilirubin is going out with the stools, so that's why the stools are yellow. And some of these bilirubin are going to be reabsorbed by the intestines, go to the kidney and eliminated through the kidney. So that's why the urine is going to become sometimes yellow. And if that's white, because you are taking excessive amount of water. Glycosuria is the presence of glucose in the urine. We have albuminuria. The albuminuria is the presence of albumin. What is albumin? Albumin is going to be protein. We have the microhematuria. Microhematuria, when you have, for example, I'm going to show you how they read how they can tell if there is 3 or 2 of these red blood cells in high power field viewing. So this is what you're going to see in the microscope. In the microscope, these are actually a chart that is having some divisions, and you are going to put a drop or 2 drops of urine here. Under the microscope, you will see that every single square you see here is called the high power field, and they are going to count not the whole amount of urine or the whole red blood cells in the urine, but how many red blood cells you have in this little square or here, and they make an average. And they are going to tell that you, for example, you have 1, 2, or 3 red blood cells. That is called a microhematuria. Okay, so this is actually the real scene when you see that in the microscope. Okay, so let's talk about some disorders of the urinary system. And first thing you need to remember always is this. We have the upper urinary system and we have the lower urinary system. The upper urinary system is going to go from the kidneys to the ureters. That is the upper. And the lower will be the urinary bladder and the urethra. Okay, so we have one thing that I want to tell you about this is, well, okay, let's start with, first of all, with the pyelonephritis and the acute glomerulonephritis. So what are these words? That most likely you're going to see very often in your practice, especially in imaging. So we have acute glomerulonephritis. So what does that mean? That is nephritis in this word means kidney. And glomerulo is the glomerulus. So it's an inflammation of the glomerular portion of the nephron. Then we have the pyelonephritis. Pyelonephritis that sometimes is interchangeable with the UTIs, urinary tract infections. Pyelo means the pelvis of the kidney, nephritis is the kidney. So we have UTIs. The UTIs is the urinary tract infection, and the most common bacteria for that, who is that? Is the E. coli. E. coli. This E. coli is going to produce and is going to ascend through the urethra, invading the urinary bladder, producing cystitis, and these bacteria can start going through the trigone, where it's going to drain the ureters. Then the ureters, the bacteria keep climbing, and they are going to affect the ureter and the pelvis of the kidney. So that is actually the pyelonephritis. Glomerulonephritis is more close to the cortex. Meantime, that glomerulonephritis is mostly what we call the upper urinary system. And the pyelonephritis start in the lower urinary tract, but they can actually produce problems in the glomerulus. In this case, pyelonephritis can lead into glomerulonephritis. One more thing, I know the time is short. You remember we have the kidneys are retroperitoneal, but there is different compartments in the retroperitoneum. In these compartments, in conclusion, what I want to tell you is that if you have an infection on one of the kidneys, because of this communication between in the retroperitoneum, the other kidney can be affected too. Okay. So let's keep going here. We have, one thing here. Here we have this distension of the ureters. And why is that happening? Because you have a blockage here, right? All right, so let's go back to this picture. I want to show you something that is what happened when you have a stone that is blocking the ureter. You need to remember that the kidney has a capsule. This capsule is a very, very strong structure that is going to keep the shape of the kidney, plus it's not distensible. So it's going to be very difficult to distend because it's very hard structure. That is called capsule. Okay, based on that. So if you have a stone here blocking completely the exit of the urine, so what you're going to see is the urine start to keep coming. It's going to keep draining into the pelvis. So this obstruction is going to accumulate fluid here more and more and more and more, and there is so much pressure that this, besides that, the capsule do not allow the kidney to distend. This fluid start to push the medulla and is going to squeeze the cortex. And when that happens, the blood supply to the glomeruli are going to just stop. So you can lead with for some calculi or stones in the kidney, accumulation of fluid, pressure against the medulla, and the medulla pressure against the cortex. That is going to produce destruction of the nephrons, can lead into renal failure, Okay? Okay, so, all right. So I think is everything for today. I really enjoyed to be here with you guys. So is there some input or something that you want to comment? Please go ahead and feel free to just let me know. Thank you. So any questions? Eddie, can you hear me? Yeah. I don't know, you can hear me? Put something on questions. Oh, okay.
Yes, sir. I can hear you.
Okay, so everything was okay? You could see the slides this time?
Yes, that was. Mm-hmm.
All right, hopefully you like it. If not, yeah, let me know too. So
Okay.
I just want to, this is in addition of the information you have. All right, thank you so much. I will see you next Friday.
Okay, sir. Thank you very much.
Thank you too. Bye-bye.
Bye. Will you be posting this on the website?
Sorry?
I said, will you be posting this today on the website?
Yeah, I will do this. I'm trying to get familiar with this, so I will try to do it today, if not as soon as possible. Thank you, Eddie.
Okay. You are.